Hi, everyone, and welcome to the Otolaryngologic Clinics Podcast series. I'm Stacy Eastman, the managing editor for the series here at Elsevier. Otolaryngologic Clinics is a bi-monthly publication consisting of review articles focused on a central topic. Today, we will be discussing the December 2022 issue dedicated to updates in pediatric otolaryngology, guest edited by Drs. Romaine Johnson and Elton Lambert. Here now is the consulting editor, Dr. Sujana Chandrasekhar, to lead the discussion.
Hello, I'm Dr. Sujana Chandrasekhar. I'm the consulting editor for Otolaryngologic Clinics of North America, and today I'm speaking with the guest editors of the December 2022 issue, which is on updates in pediatric otolaryngology. My guests are Dr. Romaine Johnson and Dr. Elton Lambert. Dr. Johnson is professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Texas Southwestern Medical Center in Dallas, Texas. He holds the Beth and Marvin Cub Professorship in Pediatric Otolaryngology. He is the editor-in-chief of Laryngoscope Investigative Otolaryngology, which is the Triological Society's open access journal. Dr. Lambert is associate professor in the Division of Otolaryngology in the Department of Surgery at Texas Children's Hospital and in the Bobby Alford Department of Otolaryngology and Communicative Sciences at Baylor College of Medicine in Houston, Texas. Welcome to both of you.
And congratulations, Dr. Lambert. Wow. I know you just got promoted to associate professor.
You just got promoted to full professor.
Yeah, earlier this year, back in February.
Well, you two have put together a really comprehensive deep dive into pediatric otolaryngology that, as I read it, I think it will benefit readers of all levels of both training and practice. And I find it really interesting when I think about people for guest editor and I think about a topic, I kind of have this idea of what the articles will cover. And you know what? I'm wrong a lot. And the way the guest editors do it is much better than the way I envisioned it. So I'm glad I was wrong about this one as well. The 15 articles in this issue cover a really interesting subgroup of topics within pediatric otolaryngology really well. And let's talk about what it covers, and we'll go more or less in the order of the articles in the issue. For our listeners, as you know, all of our issues and individual articles can be purchased at our website, www.oto.theclinics.com. Your medical library should have a subscription to the clinics, and you should be able to borrow hard copies from your library and access any material that's available online. And you can also listen to every podcast either via the clinic's website or wherever you get your podcasts. So this issue begins with an article on pediatric single-sided deafness by Hunter, Yancey, and Lee, which has really good information on etiology of single-sided deafness in children and lists very comprehensively the current cochlear implant candidacy criteria. And I encourage our listeners to read that. But let's start our conversation or triversation talking about the article. I can make up words. I'm an immigrant. Let's talk about eustachian tube dysfunction. And I'm going to address the first question to Dr. Johnson. So, Romaine, the article on updates in ETD was written by Madineni and Ahmad. So if I was seeing a teenager with eustachian tube dysfunction and several sets of ear tubes, what options do I have now for this young adult?
That's a great question, Sujana. I think there are several options if you have obstructive eustachian tube dysfunction. First, you can treat the cause of the obstruction. So if they have adenoid hypertrophy, it's controversial whether or not you can treat sinonasal symptoms like allergic rhinitis. Most people say steroids and things like that do not work. And in fact, that was recommended against it in the current guidelines from the Academy. However, you can also do balloon eustachian tubeplasty, and that has become very popular. And there's been some randomized controlled trials, at least in adults, that have shown it has worked And there is meta-analysis data on the pediatric side. Now, it tends to be case studies and observational data. It's not randomized controlled trials. However, observational data is important data that is also shown, particularly in older adolescents, that it can provide relief with obstructive eustachian tube dysfunction. And then there's also something what they delineate called patchless eustachian tube dysfunction. And again, if the patient has that, there's several options available. And I think the most popular is where you plug the eustachian tube with Celastic sheet or something like that. And that has shown to have a good relief, especially compared to definitive solution, which is the suture eustachian tube close. Because if you do that, that renders the patient needing a tympanostomy tube for the rest of their life. And of course, I'd love to hear Dr. Lambert's opinion about this article, since he's the person who thought it was important to include.
Yeah, of course. And Romaine, thanks. It's always a pleasure working with you. And I hope all of our readers really get a lot out of the articles that we assembled for this edition. So one of the major advances is the availability of eustachian tube balloon dilation. And specifically, there's a couple points that they really hit on. It's just like, what are you measuring? So there are a number of eustachian tube dysfunction surveys that can be used. So you can track patient outcomes and put forward the technology. And then usually it's approved in adults. And then our work in pediatric otolaryngology is now saying, how can we apply this in kids, and then sort of allow ourselves to lower that age where the FDA will approve it for children. However, like anything else, for a patient who really needs it, you can try off-label use. So I think those are the two bullet points: the lowering of the age and figure out when kids can get it, and then just tracking the outcomes, not just through tympanograms, but those quality of life surveys.
One of the points that we had talked about earlier before we started recording was about adenoid hypertrophy, right? So even if somebody says they've had their adenoids out, I'll tell you in the adult population, sometimes I'll look back there and I'm like, ooh, these are huge. And they're either forcing the posterior leaflet of the eustachian tube anteriorly or causing that obstruction, or they're actually physically obstructing the lumen. So, when you make it a 15 or a 16-year-old person, well, that's almost an adult. It's very different if you're making it an 8-year-old or 10-year-old or 12-year-old. And certainly we have some way to go with that. Shall we move on to DICE, which is drug-induced sleep endoscopy? The article in this was written by Kirkham. And I wonder, Elton, Dr. Lambert, but Elton, if you can tell me the role of DICE in managing untreated and residual pediatric obstructive sleep apnea after an initial tonsillectomy or tonsillectomy and adenoidectomy. And I'm very curious, when you decide to do it, how do you score the findings? How do you counsel the parents that, because you've taken them to the OR, you've done the TNA, they have a really high expectation of excellent results in their child's sleep apnea and all of the symptoms that come with that. But now you're taking them for this. So what is the counseling and how should we understand it?
Yeah, I enjoyed reading this article as well. Romaine picked this, so we're going to complement each other. But the role of DICE really started out with, as the article outlines, like those children who have persistent obstructive sleep apnea after adenotonsillectomy. And as I counsel parents, just like, if the adenotonsillectomy, if that's not, or it just gets progressively harder to get a good result. And the first thing to do is just to define where in the airway the persistent obstruction will be. So first counseling, I think there's a lot of us who may do adenotonsillectomy based on the guidelines and getting a sleep study first versus just by parental report. But really, if you're getting into the realm of residual obstructive sleep apnea symptoms, and you do need a sleep study to document and then guide treat. That is for sure. After that, in terms of the scoring criteria, so in the article, there are a whole host of scores that you can go through that can score the DICE procedure. In general, like each one of them is going to take one of the major areas where a patient can have residual obstructive sleep apnea: the nasal cavity, the nasopharynx, velopharynx, the oropharynx, the base of tongue, oropharynx, the larynx. And as detailed, each developer of each survey puts onus on each one. And the readers can go into details for each of the scores. But like what's really important is just getting a sense of defining where the residual obstruction is coming from, and then subsequently tailoring your surgical management and address those areas. I think all of us know there are some groups of patients where, like, even before your adenotonsillectomy, there are a high risk of having residual obstructive sleep apnea. And those are your Down syndrome patients, the patients with craniofacial disorders, those that have neuromuscular disorders, and those that have obesity and BMI 95th percentile or over 99th percentile. So a lot of us has asked the question, well, if we're doing DICEs like on the back end of an adenotonsillectomy, like what patients may need to have a prospectly at the time of adenotonsillectomy? And there's two sides to a coin. Well, every time you're doing a DICE, it's not just another scope procedure. It has its own risk and it takes up time. And ultimately, if you're going to have increased risk and more time, like, is it going to be beneficial? So I think, there is some role in patients where you as a practitioner think that they are at a high risk for residual obstructive sleep apnea after an adenotonsillectomy. Then I think adding the DICE is a good option. However, the jury's still out on whether that is going to be best practice, because frankly, there are going to be some practitioners who will say a patient who has Down syndrome is at an increased risk. If they have 4+ tonsils, I'm going to do an adenotonsillectomy. And then if they do have residual, then do my DICE instead of exposing the patient to increased time and resources for it.
I really like that. I wonder if I can prevail upon you, Romaine, to add a little bit regarding how you might talk to your anesthesiology colleagues, whether you're only doing DICE or perhaps looking to add DICE at the conclusion of an adenotonsillectomy. And I know that there is a really good table in there that I thought was very helpful in terms of the drugs that should and should not be used.
Yeah, I think definitely refer to that table as you talk to your anesthesiologist about how you're going to approach the DICE. I think most otolaryngologists prefer dexamethasone to give the anesthetic. They feel like it provides a good anesthetic plane. You still have the patient breathing spontaneously, and you can stimulate, snoring. Essentially, you want the patient to be awake enough where they snore or they obstruct, but not so awake that they're reaching up and grabbing the scope and pulling it out. And so I think Dex is one of the more common ones that people prefer. However, propofol is reasonable too. It just depends on your anesthesiologist. Again, I think the key is talking to them ahead of time, letting them know that you want to do sleep endoscopy and that you want them to have a preferred plane where they're asleep, they're snoring, they're obstructing, so you can see the level of obstruction. I personally don't do DICE at the time of adenotonsillectomy. It's my personal opinion that the anatomy is going to change after you do the surgery. And so you're going to get a totally different exam after adenotonsillectomy is 6 months later, a year later, whenever you have to repeat it, if they're residual OSA. But it's not unreasonable if someone chooses to do that just to help with their overall thinking about the patient and understanding their anatomy and where they're likely to obstruct in the future.
Thank you. Let's go on to drooling. So, the first time I learned as a resident that drooling is something we take care of, I'm like, what? But we're talking about drooling, right? We're talking not just occasionally you wake up and your face has sealed itself to the papers you fell asleep on. But these are children who really have severe hypersalivation. And you wrote, Elton, the article on drooling and aspiration of saliva with Dr. Hughes. I really appreciated that you provided some tools so that when clinicians speak to each other, whether it's physician-physician, physician speech and swallow therapist, physician-nurse, that we actually are comparing apples to apples and we're actually discussing the same thing, because this is relatively young nomenclature that we have to really standardize. You talk about a number of treatments, and that includes anticholinergic medications and botulinum toxin injection, as well as salivary duct rerouting. So I wonder, just for the purpose of this podcast, I do encourage all of our listeners to read the whole article. It's really good. Can you talk about how you do ultrasound-guided Botox injections? What age do you do them? In what setting do you do them? And how frequently do you do them?
Really want to thank Dr. Hughes for collaborating me on this article, since she has a passion for this patient population as well. For me, when it comes to choosing interventions, whether it be the injections with botulinum toxins, any of the surgeries like ligation, rerouting, and submandibular gland excision, the first is just to see what is the impact, social implications. And you can really have a lot of leeway in terms of age and when to do something. If there is more respiratory complications or respiratory morbidity, that's when it begs the question, you have to be more aggressive. That goes into the age question. So a lot of patients will have drooling, which is up until age 4. In patients who don't have a lot of respiratory complications, then I think it's fine to wait till at least age 4, unless their underlying comorbidity has a known sequelae where they're going to have a significant amount of drooling, or it's so unreasonable. There are so many times a day that they're going to put themselves at an aspiration risk. And I think the lower age group, I myself have done definitely less than a year of age. But I do think it takes the conversation with all the subspecialists that are involved in the care, including pulmonology, neurology, PM&R, rehabilitation, just to get a sense. So for age, anything over 4, I think that's when you can start to offer more widely, but lower than that, definitely, just like anything else, requires multidisciplinary conversation. The other question that tends to come up is well, are you going to do the injections with sedation? There's really no good data on that. However, doing it in the OR resources increase costs. And I have just found that families, especially with our medically fragile children, the families really kind of know their tolerance level best. And if they say we have to do this honor sedation, then I tend to listen to them. And then if they think that they're going to come off this with local anesthetic, then that's what we do, and rarely have ever seen it to be an issue. And then in general, in counseling, it's important to tell families when they can expect it to start working. You have to really tell them it's not going to start working the same day. It takes at least a week. Maximum effect is 3 to 4 weeks. Sometimes you have some late responders that you thought never worked, and the family tells you later that it does work. In terms of duration, the cosmetic applications for botulinum toxin injections, they're more reliable. Every 3 months, most patients need that. But some of your parasympathetic driving applications like drooling, it's very much variable. I found average tends to fall between 6 to 9 months, but it can be longer, it can be shorter. But then there's all these moving targets. You have a young child who, like, you expect to last 6 to 9 months, but they may actually pick up more, like, oral motor skills. So those oral motor skills will affect their ability to do more. So that's how I counsel. And then that is an eventual expectation I have for them. And it may pan out differently than I expected.
I definitely appreciate that. And I agree with you. I think if you are patient and explain things to children, I'm very surprised at how well children can tolerate things in the office. You know, moms and dads sometimes know their kids. And I think you're right. Allowing for that is very important. So you mentioned multidisciplinary teams and multidisciplinary approach. So I will confess that I have been a big fan of Romaine Johnson for quite some time. And then sometime during the pandemic closures, he burst back into my consciousness, giving amazing grand rounds on the multidisciplinary pediatric tracheostomy team and how he envisioned and effected change, incorporating not just multidisciplinary healthcare teams, but actually understanding the socioeconomic determinants of healthcare and wellness and training and education. So really, if you thought I was your fan before that, I became a super fan. So I wonder, Romaine, if you could talk to us about multidisciplinary pediatric trach care teams. You wrote an article with Drs. Cow and Chorney, and as you say in your article, tracheostomy is seen on Egyptian tablets dating back to 3600 BC. We can all pretty much do a tracheostomy. Like, I'm an otologist, I can trach somebody. But we also know that children with trachs are among the most vulnerable and fragile patients in our healthcare system. And in fact, it used to be understood that a child with a trach had much more danger coming into the hospital for their healthcare than at home with their primary caregiver who actually knew how to take care of them. So what is the evidence that multidisciplinary teams improve patient outcomes? And what do you think are the most critical components of such a multidisciplinary team?
Let me say, I'm just a big fan of you as well. In terms of multidisciplinary teams, I think that's just true across the board. If you can get people in a room who have different areas of expertise and get them focused on a singular project, you know, two minds are better than one, right? Even Dr. Lambert just spoke a few minutes ago about drooling, you know, having a drool clinic where you have a speech therapist, an otolaryngologist, maybe you have a physical medicine and rehabilitation doctor, maybe you have a neurologist there too. It's going to improve the impact that the care has on the child. And I think tracheostomy is particularly important because, like you said, those kids are vulnerable. We all have seen situations where a trach change has gone bad. We all have seen where a child who seems to be pretty stable has a mucus plug and has a serious event. And realistically speaking, they're also pretty sick. When you put a trach in a kid, you know, in adult practice, they may be a head and neck cancer patient or a trauma patient. Head and neck cancer patients are pretty sick, but a lot of times you think the trach's going to come out, you're doing it for their therapy, or a trauma patient. But with a pediatric patient, you're often thinking like, okay, this trach's going to be in for years. They're premature, they're on a vent, they're highly vulnerable. And the evidence show that trach kids get lost to follow-up. Trach kids, there's trouble educating the families and in getting them home to discharge. They have prolonged hospital stays. They eat up a lot of costs because they're in the hospital a long time. Something like, you know, less than 1% of trach kids exist in the country in any given year, but they eat up around 5% of all hospital costs. And so what we saw at Children's was all the things that other people see. You know, they're in the hospital for a long time. There's chronic decannulations on the floor. They're in and out the hospital. They have high costs. There's no standardized education. And so we came together to put together a trach team. And some of this was inspired by the GTC, the Global Tracheostomy Collaborative, but they did a lot of the adult data. And so there wasn't a lot done on the pediatric side. We built a team. We found a nurse practitioner who's willing to be a part of the team. We found inpatient nurses who would be a part of the team, outpatient nurses, respiratory therapists, speech pathologists, and then otolaryngologists, social worker, case managers, business managers. And we just kind of brought everybody together and said, okay, we're going to build a team. And we use something called the scorecard, which is like a business scorecard. It's a lot of people use it for business projects, but we incorporated it into our healthcare project, our trach team project. And we looked at, okay, we're going to reduce length of stay because that's important. We're going to make sure every kid gets speech therapy and communication therapy. That's important. We're going to make sure that we reduce the time to trach education because that's important. And then we had all these metrics. And then once we started to measure those things, we slowly started to see where our deficiencies were. And then we started to build processes to bring those things down. And then we were able to show, it took a while, but it was able to show after a year or two that we were able to reduce the length of stay, particularly the post-op length of stay. And as a result, we were able to reduce the cost, particularly if we were to get patients out the hospital very quickly. And then I think it also became like a model for the hospital. Like now when people want to build a multidisciplinary team, they come reach out to us. When people talk about how you can impact, critically ill children, particularly those who are in and out the hospital, who need both inpatient services and outpatient services to kind of coordinate the two, they come look at us. The team has been a real pleasure. I've actually gotten to the point where now I've passed the reins on to another physician. Like they're now the medical director, and I'm the old guy who provides advice in the background to keep the train rolling.
I love when I become the old guy for many things. It's quite joyous, I must say. I like the infographics on your child's tracheostomy journey and the benefit of using that scorecard. It's really interesting that you incorporated sort of business speak, because some of it, not all of it is bad, some of it is good. And I think that's something that people can learn from. What I was struck a lot by was that by you sort of setting the recipe or the outline of it, people don't have to be at a big medical center to do this. Like if you can set this up at a community hospital, at a relatively small institution, and still have the buy-in and still have the good outcomes. I think one of the things you talked about both in the article and in your grand rounds was, thinking about, do they have the ability to suction at home? We happen to be recording this in a time where there are big communities in North Carolina where the electricity's been taken out. And so cell towers aren't working there. And, even 911 access is difficult. Man, if you have a child in a home there who needs suctioning, you need to do something about that. And I think that we become better doctors when we realize that we're not separate silos between the operating room and the clinic, or the hospital building and the neighborhood. And I really laud you for that. You talked about head and neck cancer, but you talked about an adult. So let's talk about head and neck cancer in children. Elton, you guys included an article that was written by Demachke and Chelius, and that covers 3 R's of complex head and neck care. So resection, reconstruction, and rehabilitation in children. And unfortunately, this is a growing field. I guess it's fortunate that we're able to identify and intervene in children. It's very difficult, obviously, for all parties concerned. So again, let's hit the highlights of a multidisciplinary team for these patients.
Just like with anything that tends to be like a rare occurrence, where you have to have like very specialized teams, and rare occurrences, when we're talking about head and neck resection and reconstruction rehabilitation, it is a broad array of pathologies. And then specifically, our readers will see in the article, like the highlighting cases of one child who had desmoid fibromatosis, one child who has aminoblastoma, and then one that had a neurofibromatosis, which was affecting the lower cranial nerves, like very separate entities, but it's really like what space are they occupying necessarily. Like after that, I really liked the way they laid out an entire flight plan for the patients. So like not only thinking about the resection itself, but having an eye towards like, how do you get them rehabilitated? How do you get them to have dental restoration so that they can have good mandibular growth in the patient who needs a fibula-free flap reconstruction, for example? And all that it needs to be coordinated in a very sophisticated way, which includes our theme of team sport and a multidisciplinary team, not only the oncology head and neck surgeons, the reconstructive surgeons with specific microvascular expertise. Like one thing our microvascular surgeons will talk about is that you have to have knowledge of the relative size of your donor and recipient vessels in adults versus a 3-year-old child, like very different expertise that is needed in those cases. Your speech pathologist, physical therapist, occupational therapist, and seeing how like everything and every person fits in. And also the coordination for the surgery. So like I remember as a sub-I like trying to like help with the fibular flap reconstruction where like you're holding up a leg for hours just trying to team out. And you feel like you may have a full-size adult like 5 to 6 feet away from you while they're working. But if you're working on a fibular flap reconstruction on a child 3 to 6 years old, then that is a small amount of real estate to try and coordinate a resection and subsequent reconstruction, especially when you have simultaneous flap harvest and resection going on. So definitely the flight plan with an eye towards rehabilitation, seeing how not everything's just going to be coordinated. Is the people involved? How is it all going to fit together is important. And like starting to think about the out of the box with our protocols and adjustments to our protocols. So as we all know, for our pediatric tracheostomies, we have specific protocols, especially in the children that need long-term ventilation with BPD as a comorbidity. Now, if a child with a head and neck cancer requires a tracheostomy, and we know it's a finite period of time that they need to help with free flap reconstruction, airway protection with like a bulky flap, that's a very finite period of time. So you can't necessarily use the same principles of decannulation protocols for the BPD children who are going to have their trachs for 2 years plus or minus a few months, and the sequelae that can accumulate from that versus the child who may just have an inpatient tracheostomy for 2 to 3 weeks. And one of the things that was highlighted, the ability to make or formulate rapid decannulation protocol for head and neck cancer patients who have received a tracheostomy. So those are the things when you start to like look at the entire picture, you can kind of figure out where the pain points are and what you can do to tailor each and every type of point in the treatment for the child.
I didn't even think about the fact that the children are so small, but the 2 surgical teams are adult surgical are adults who, are your nurses and your techs and your surgeons. And you're right. It's a very complicated dance to maneuver, as you said, with that flight plan. And I'm just going to confirm BPD means bronchopulmonary dysplasia.
Correct. Yes.
So the next article, which is by Rosenberg and Phillips, covers vascular anomalies. And we actually devoted an entire issue of Clinics in February 2018 to this topic. But I found this article to be an excellent refresher And I particularly direct our listeners to the algorithm they've included for the evaluation and management of airway infantile hemangiomas. It was extrapolated from the Darrow article in the prior clinic. So I really like that article, recommend that you guys read it. I'm Sujana Chandrasekhar. I'm the Consulting Editor for Otolaryngologic Clinics of North America, and today I'm speaking with the guest editors of the December 2022 issue, which is on updates in pediatric otolaryngology. I'm speaking with Dr. Romaine Johnson of Dallas, Texas, and Dr. Elton Lambert of Houston, Texas. You can find all the issues and articles of the clinics in your personal or institutional library, I hope, and at www.oto.theclinics.com. You can also find the podcast per issue at that same website or wherever you get your podcasts. Let's move on to aerodigestive approach to the pediatric chronic cough. That article was written by Jian, Gatliff, Mai, and Wang. And I'm wondering, Elton, how does a paradigm help you improve the diagnosis and treatment for children who present with chronic cough?
Chronic cough is this symptom that can definitely occur due to a lot of different symptoms. One of our roles is trying to figure out what the upper airway digestive tract pathologies, whether it be sinonasal or in the area that may cause the chronic cough. But obviously there are other types of pathology from the gastrointestinal tract as well as the lower airway that can lead to cough. So one of the first things, and I really appreciated how the authors put is how can you simplify this very complex issue that can be frustrating for families and frankly frustrating for practitioners who are trying to figure out the diagnosis and what we can do to help. What they recommend is a three-pronged approach. First, does it sound like something that as a seasoned practitioner you can recognize just based on the quality? And we all in pediatric otolaryngology are trained to think about the cough of a child who has tracheomalacia, whether it be Barkey washing machine-like, there's like this instant. And one of the things in terms of our trainees, we train them to know that cough. So if it's something like that, there are going to be various treatment algorithms that the patient will opt on in terms of evaluations with flexible and rigid bronchoscopies, or various cross-sectional imaging in order to diagnose, for example, tracheomalacia. And then beyond the obvious, we know what this cough is based on what it is, then the quality of the cough and the duration as well, that helps us to narrow down what may be occurring with the child. So child has a wet cough of 3 to 4 weeks or more of duration. We all think of protracted bacterial bronchitis, which within the purview of our pulmonologists, but if you are within an aerodigestive group, you just get used to having the ability to, if a child shows up in your clinic as a pediatric otolaryngologist and they fit that criteria, you know exactly what the patient needs just based on that pattern. Beyond something like that, then you have to answer if they have a wet cough, which is your sign of increased secretions in the airway, decreased clearance of secretions in the airway, and what's causing these secretions in the airway clearance issue, or is it something like aspiration of liquid food secretions in our patients who have laryngeal cleft, as well as tracheoesophageal fistulas, which are causing that wet quality to the cough. And then finally, the authors talk about whether a patient has a dry cough or not. And that specific diagnosis of a dry cough, especially when there's specific triggers in patients who it may be a seasonal trigger or an exposure trigger, some sort of reactive airway disease, including asthma. And with that, you can start to treat patients with asthma medication or inhalers such as inhaled steroids. But definitely theme of our conversation, definitely conversations with a lot of your colleagues from this is different subspecialties so we can diagnose and then treat effectively.
That's the point that has been hammered home a lot. But I think this algorithm is very nice, right? Because the patient's parent is bringing them or caregiver is bringing them for something that they've often been somewhere and somewhere else and somewhere else, haven't achieved any sort of resolution. Looking at it rather pragmatically and systematically, allows you to put it into the buckets and maybe get the child the care that they need. And maybe the parent can have a good night's sleep. Like that's always a good outcome as well. So let's move on and talk a little bit about 3D printing. So I'm really impressed with the speed with which 3D printing has gone from an interesting and time-consuming academic exercise. And in fact, I remember going on college tours with the kids and them showing off their huge 3D printer. But now it's a technique that's actually got really good clinical use. So the article by Pengyu and Bartelis on 3D printing in pediatric otolaryngology covers quite a bit. So, Romaine, what are some of the applications of this technology that we can use now to enhance patient care?
I agree with you. It is interesting how now 3D printers are widely available. At my institution, I think we have like 5 in different parts of the campus. So there's 2 levels to it. So there is kind of the future, and then there's what you can do now. There's this other thing. When I ask the people who use the 3D printer a lot, I always ask them, well, what do you use it for? And they say custom parts. They use it to make custom parts or create some little jimmy that they have to use for something like, oh, yeah, I needed a part that would keep this machine from falling over. And for us, one of the big custom parts that we need it relates to the airway. And that's where 3D printing is used quite a bit in pediatrics. The idea is, can you take a 2-dimensional image, which often is what we're using with endoscopy, as well as pictures of endoscopies, as well as CT scans, and can you build the airway in its 3 dimensions so you can really understand its anatomy for purposes of reconstructing it? So if they have a complex tracheal stenosis, if they have complex tracheal malacia, could you build a stent that you could use as a scaffold, an external scaffold, or could you use it as an internal stent to keep the airway open? And can you use it for teaching? So one of the big things that they're doing now with 3D printers is they're building out a lot of different tracheal rings and complex tracheal stenosis, and even laryngotracheal stenosis, and using that to teach fellows and residents how to approach these lesions surgically. And I think it's helping them. In fact, that's the big focus of the Academy's simulation program. And I'm sure they'll get a big focus as well, or next year's meeting as well. The other thing is, using, again, custom parts. So you have a craniofacial lesion, and now you want to create a custom implant, or you have a defect in the tegmen or the anterior skull base. And again, you need a customization to reconstruct it. You want to try to get just a little bit better at fitting the thing in there, the graft or the plate or the implant or whatever you're using. Just make it a little bit better so you're not on the table like, okay, 2 millimeters here, 3 millimeters here. Those are the things where I think 3D printing is most useful. Surgical planning, potentially airway stents. The next level, again, thinking about custom parts, is, can we create bioavailability? Can we use tissue engineering? So now you create a 3D implant and you use tissue engineering so the body uses that implant to rebuild the trachea as it's supposed to exist. I know, I think it's Dr. Chang in Ohio State. He's doing a lot of custom scaffold work, tissue engineering, tracheal engineering. When that happens, it's going to be phenomenal, not just for kids, but for adults too, because we know that there are complex tracheal stenosis patients who've already had multiple reconstructions and they're kind of like, their airway's a disaster. And what can we do to make their airway better? And this idea of creating a custom trach with a 3D printer that's bioavailable and bio, specific, that's the future.
That segues beautifully into the next article, which is on slide tracheoplasty. And this article was written by Richardson, Hart, Johnson, and Gerber. As they point out, congenital tracheal stenosis is seen in 1 in 64,000 births, and the most common cause is complete tracheal rings. And that occurs when the posterior membranous trachea fails to develop during the 8th week of gestation. So I didn't remember really until I read the article that just a minimal reduction in size of the infant airway, like by 1 millimeter, can actually decrease the luminal cross-sectional area by over 40%. So, these kids can take a really big hit with even something that's a relatively small stenosis. So can you talk to us a bit about what is slide tracheoplasty? How do you use that in treating this really unfortunate congenital anomaly?
Thing that I like about this article, and the reason I invited the authors to give it wasn't just to talk about slide tracheoplasty as a way to treat congenital tracheal rings, because now I'd say the last 15 years, it's pretty standard. If you see a child with complete tracheal rings, particularly a longer segment, I guess if it's a very short segment, you can still do tracheal resection. But for long segment complete tracheal rings, in the past, you would do pericardial patch. Maybe you would try to do a tracheal resection. Maybe you would just try to wait it out and see if they grew. And the morbidity and mortality was actually quite high. But with slide tracheoplasty, which is in effect, you take the trachea, you look at the length of the complete rings, you split the stenotic segment in two and equally, and then you release sort of inferiorly on one side and superiorly on the other, and then you slide the trachea on top of each other and then resuture it back together. So in effect, you make the trachea shorter and wider. It helps take care of that problem you were talking about where the lumen is too small. When you make it wider, it has revolutionized the care of children with complete tracheal rings, where now the mortality rate is very low, probably less than 5%, especially if they don't have other congenital problems. Now, obviously, some of these kids are very sick and they have heart disease, et cetera, et cetera. But isolated complete tracheal rings now, it's not considered a long-term morbid problem. They should be able to have a pretty good result. But the thing that I like about it is that folks are getting innovative with it. They're realizing that you can use slide tracheoplasty for long segment stenosis that's acquired. So some of those patients that have had, tracheostomy tubes for a long time and had significant injuries, they have long segment stenosis, pretty severe tracheal stenosis due to the tracheostomy tube. You can use slide tracheoplasty in those instances too, so you don't have to resect as much of the trachea, and you can get pretty good results. The other thing is they're using it for tracheoesophageal fistulas. So for people who require, either residual after an attempted primary repair, or they developed it due to an acquired condition from a tracheostomy tube and say an esophageal injury, you can use it for that too. And so they're also using it for like severe suprastomal collapse. And so it's great because one of the problems is, if you resect a piece of the trachea, it's gone forever. You burn that bridge. But with slide tracheoplasty, you preserve a lot of the trachea. So, and you use the natural tissue that's already present to try to maximize healing. And so that's what I really want people to get from the article, is to start to not only look at how the history of complete tracheal rings and how slide tracheoplasty can treat it, but also how now surgeons are being innovative with slide tracheoplasty, and they're figuring out it can be used for other applications as well.
I like that. It's going to become sort of like this workhorse for preserving that which we cannot create and making it work better, right? Elton, I know that your institution has a lot of experience with airway management.
We're evaluating a child for slide tracheoplasty. One thing is whether the pathology where you're planning to use or utilize slide tracheoplasty, is it within the cervical trachea only, or is it intrathoracic? Because, for example, there are some patients who had cervical tracheoesophageal fistulas, or definitely would it be suprastomal collapse, or short segment tracheal stenosis, which is cervical, then that is something where like you can really have a pediatric head and neck airway surgeon do the resection and anastomosis totally. However, like especially for a long segment and a good majority of the congenital tracheal stenosis, they are intrathoracic. So definitely partnering with your congenital heart surgeons or specifically your cardiovascular surgeons to help with the intrathoracic approach, as well as any maneuvers you need to take the tension off of the trachea to get a tension-free anastomosis. And that's definitely important as well.
Thank you. Yeah, I think you're right. It'll be different if you're looking upper or in the thoracic. That's a good distinction to think about. Pictures in that article are exquisite. So strong recommendation for our listeners to go back and just, enjoy the pictures because they're beautiful. So Elton, ERAS or enhanced recovery after surgery is something that's very common in the adult literature. It started in general surgery and really had its origins in minimization of the need for dramatic pain management postoperatively. I think we actually did a whole issue on anesthesia and otolaryngology, and we talked not just about medications, but acupuncture, about counseling, about different things that can be done. So is there a role for this in pediatric otolaryngology? And I say that because you included an article on enhanced recovery after surgery written by Kitchen, Raman, Javins, and Jatana. I think they're all out of Nationwide Children's Hospital, which is in Columbus, Ohio.
In pediatric otolaryngology, we definitely would talk about the complex procedures that we will do, but like a lot of the practice is still short, high throughput, large number of surgery procedures that we do day in and day out. So as a result, our specialty, both within children's hospitals, among different pediatric surgical subspecialties, and within otolaryngology, is very, very exquisitely sensitive to processes surrounding efficiency. And then efficiency, going for anything that will make the process more efficient, whether it be preoperatively, intraoperatively, and postoperatively. Because we are so sensitive, anything that throws that off, and there's so many details that can throw off that efficiency, is just magnified. You just think if patients are being prescribed too many opioids, then that just gets magnified because of the number of patients that we are prescribed prescriptions on. If we aren't using hospital beds effectively, then the number of patients that we're using, it just magnifies. So I think you go down the list of everything that they touch, whether it be ED returns, readmissions, you go down the list and you think it has a clear role because of a volume of patients that surgeries are performed on, and 8-hour to 12-hour time period, like the number of patients that are fitted into that area, preoperatively, intraoperatively, and postoperatively. I really enjoyed the figures where they broke down each of these phases. And some readers may look at it and say, well, each one of those things is that I do, is this really necessary? But at high throughput specialty, you can miss one of the things. Like maybe at the forefront of a surgeon's mind, you're not thinking about the role of decreased anxiety in a patient, how that affects the amount of pain medicine that they are receiving postoperatively. But it makes a big difference. And if you don't take into account one, that's one thing, but you take 20 patients in a week and going throughout the weeks and year, you can see the definite benefit from having these protocols, and it improves patient care, patient satisfaction, and decreases resource utilization so you can take care of more patients with the same amount of time, effort, and energy as well.
I love the way you put that. I was really impressed by their data that they looked at between 2018 and 2021 having established these protocols, they were able to reduce opioid prescription by 77%, the number of opioid tablets given by 56%, discharges were decreased, the returns decreased by 51%, the non-operative readmissions decreased by nearly 60%, and the operative control of post-tonsillectomy hemorrhage basically was decreased by nearly 70%. So we may be the greatest surgeons on earth, but if we are operating in a silo and we don't have these protocols in place and these, proper expectations by the child and the caregiver, I think then, maybe our statistics don't reflect the greatness of our surgical skills.
Yeah, and then it just also shows that standardization works. There was probably some degree of variability in practice. Maybe one surgeon wasn't doing as many opioid prescriptions, and maybe one was paying attention using our child life services to decrease anxiety in child. But then when you take the best practices of each and then you put it in a protocol where, frankly, you can just have somebody use heuristics to just go through and use the standardized pathway. And then I like standardization, especially in these cases, because somebody has used evidence-based to take some of the guesswork of these standardized areas for you so that you can concentrate on the deviations, really have your mental focus on those deviations and have the protocols do their work for the patients and for the hospital system as a whole.
Right. You don't want to waste what mental energy we have thinking about something we don't have to think about. Of course, you're going to think about the person who is on the table right then and there. But if everything around it is standardized, you can just focus on what is important in that interaction.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we are discussing today by visiting us.elsevierhealth.com/expert.
You use the word heuristic, Elton. I just want to point out. And Romaine, you already talked about incorporating sort of big data kind of ideas, business type of ideas to try to improve quality as we deliver it to our patients. You guys included an article by Lavin and Ida on quality improvement methodology. So why is understanding QI methodology crucial in creating initiatives that are likely to achieve lasting results? And I know, Romaine, you have an MPH and you're a full professor. Do us mere mortals have to go and get more education? Or is there a way to, again, reach out to people in our environs to help make this happen?
So, no, you don't have to get a master's in public health to do quality improvement. In fact, I think it's critical, and I mentioned that at the grand rounds that I gave for Northwell, that you should incorporate quality improvement into your practice. Somehow, some way, you should incorporate QI into your practice because you won't know what your blind spots are and where you need to improve if you're not actively looking at your outcomes, your processes, and your balancing measures, which are some of the things that were mentioned in the article. But I think outcomes and processes in particular are things that everyone can look at. And it can be quite simple. How many phone calls do you get a month after a tonsillectomy? That's something you can do very simple. And then you can say, okay, not only am I going to track how many phone calls do I get, I'm going to track why they call me. This was a simple QI project that we started. We created smart phrases. We have a nurse who would enter the data every time we called. And then every quarter, we would look at the statistics. And we started to notice something. About 10% of all our phone calls were school notes. Family needed a school note. That's a quick fix. Why weren't they getting their school notes? So we educated the nurses. We made sure that we tried to give it to them ahead of time. We created smart phrases and Epic, and we really tried to emphasize again and again, hey, make sure the family gets a school note before they leave the hospital, before they leave the PACU. And we were able to reduce those phone calls down to less than 1%. Now, there's some phone calls that still keep happening, like my kids in pain. Like, we haven't figured that one out yet, but we're working on it. And I think Dr. Lavin and Dr. Ida did a great job of just giving you the basics, because really that's all you need. The basics. Like, for example, they said, okay, use something called SMART. It's an acronym: specific, measurable, attainable, relevant, and time-based. If you want to write a paper, what do? You sit down and say, okay, I'm going to write the introduction. I'm going to do 2 hours on Saturday, and on that day, I'm going to get all my bibliography done. Stuff like that. Same thing with quality improvement. And that's why I included this article, and I invited these authors to do it. And you could actually see a theme, I think, even previously when we talked about the ERAS, advanced recovery after anesthesia or after surgery. That's also quality improvement, right? You're saying we want to reduce the amount of opioids people take. We want to make sure that we don't have any blind spots. Another blind spot that we forget, and I thought about this, Elton, while you were talking, is pastoral care. Like, that's one of them. Like, it's been shown that if you provide pastoral care to a lot of families, it enhances their recovery. But how often do we think about them? How often do we include them in our decision making? Do we actually know what they do? When's the last time you actually spoke to them and said, hey, what's your practice? You can get a degree in clinical pastoral care. I think this topic's very exciting. I could talk about it all day.
When you talk about pastoral care, I have another gig. I have a show called She's on Call. And, we did a lot of video shows. We did 59 video shows between June of 2020 and December of 2021. And one of our guests is a specialist in spirituality and healthcare, and really not imposing one religion or one set of beliefs, but engaging the physician, the nurse, the caregiver, the patient, everybody where they are spiritually. And I think, I've had plenty of Roman Catholic patients come in. I happen to be Hindu, and say, oh, I hope you don't mind. We went to church and we lit a candle for you, so our family member would do well. And I'm like, oh man, I will take all the help I can get, and it's wonderful. To me, it's a huge mark of honor when patients will trust you with their understanding of spirituality. And you're right. I think it's something we know, but unless we say it, again, you can't measure it. You can't be actionable about it. Very nice. I did a little actionable item thing of, this is the project I wanted to present for my thesis, and these are the parts that needed to go into it, and here's my timeline. And so I think you can use these ideas for your clinical practice to see where you are, and also to move along with your career or your personal life. So we're referring to continuing medical education. We're referring to, of the three of us, you are the younger of the three of us. But frankly, you get out of training and you suddenly start inching towards that old guy who has to give up the leadership of the program to somebody younger, right? We're all making that inexorable march to being, too old to understand what the youngins are talking about. So I found it really interesting that you guys included this article on the principles of adult learning that's written by Gantwerker and Lee. Children learn in one way and adults learn in a different way. And, these are really high stakes knowledge that we're trying to pass while we are taking care of patients, while we are doing, our dumb electronic health record, while we're doing all the things we have to do during the course of the day. So can you talk a little bit about the take-home points for adult learning?
If you're in academic medicine and you're teaching and instructing residents and fellows, you want to impart upon the listeners, just remember, with medicine, you're always teaching adults, whether you have an advanced practice provider you have to teach about tracheostomy care, for example, whatever your clinical area is. your new medical assistant, a nurse that you're working with, packing nursing, about new protocols. Like, you're always having to teach, so you have to understand like how to teach them and how they are going to learn. And your education is one of my passions. I'm being involved in our fellowship and residency program. And I like how the authors really broke it down into like the principles of adult learning. And the first one is like motivation. And I would say that that's a good one to start with, because that's one of the things that I worry about the most in our adult learners. How do you motivate them to learn? How do you even bring them to a place to understand like whatever modality or whatever way they learn best, whether it be by reading, writing, videos, and everything like that, they have to come to a place where they want to learn. What do adult learners, what do you need to know? So like when you're in college or medical school and learning about like every little detail of the prep cycle, it's something that you have to know to get to the next step. But like the further you go along in adult learning, you want to know why you're learning the thing that you have been asked to learn. Do you want to know, like adult learners, you have to like know exactly how you're going to achieve the learning and in the way that you want to learn. So I still think it's important to give the adult learners constructs. Like you can't just say, okay, go watch whatever YouTube video you can find. I think that's starting to give like too much autonomy, but you have to recognize just some people prefer reading, some people writing, kinesthetics, like feel, use models, giving them a construct, but understand they have the autonomy. Also knowing where your learners are coming from, what sort of prior skills, knowledge, and attitudes that they're having. Adults get very bored when they have heard information rehash. You really want to know exactly where they're coming from before you just give them more information. Their readiness to learn, and then their orientation to learn. It's like what's the global take home, like what you are expected to get from the program which they're trying to learn from. And there is a wonderful figure, like figure 1 of the article. It's a nice summary. Kind of breaks down what the influences are for the learners, that is vicarious learning, prior performance, verbal precision, and their emotional state. But just like anything, you have your inputs and just like, what are your outcomes? Like, how are you going to say, oh, they have learned? And outcome in this case is self-efficacy. So are they going to be persistent on a task, or do they feel like they have enough information that if they hit a roadblock, then they're able to push through? I really like how they describe for our trainees, and you want to keep them not in a mode where, they always feel like they can do a task autonomously and they don't need any help. But you don't want to make it too hard so that they feel deflated, don't want to do anything. So you're going to keep them in a very nice area where you're pushing their boundary, what they think they can do with appropriate help. Are they going to push the envelope, approach new areas versus avoiding? And in the essence of continuing education, like, are they going to continuously perform in the future with what they have learned? So very, very, very nice article.
I left academic medicine quite some time ago, and I will tell you, in private practice, having younger people come in and sort of show them the ropes and be accessible so that they do develop that self-efficacy, right? You know how to diagnose those coughs, without even thinking, right? But the junior resident does not. I can glance at an audiogram and I know, I've already got my paragraph ready to go in my brain. One of the things they talked about was, kind of taking them to a step and then allowing them to do the next step. It was a little crazy of like making a myringotomy, putting a tube half in the myringotomy and letting them put the tube the rest of the way. Possibly we would do that in a surgical trainer, I'm thinking. But that sort of thing. And I think that continues as different generations continue to communicate with each other and bring different strengths to that, two-way communication. We have reached, in fact, a terrible milestone. The third year since the patient zero contracted what later became COVID-19. We have finished 3 years of a worldwide pandemic with intermittent significant closures, and we're entering our 4th year. We are seeing at this point more hospitalizations than we want. We are seeing another wave coming in the Northern Hemisphere where it's cold and people are more indoors, and only the doctors seem to be dumb enough to be wearing masks these days. So I wonder, Romaine, you included an article by Rickert and Rabar, and in Pediatric Otolaryngology and COVID-19, there's been a lot about strep A and about the retropharyngeal phlegmon and what are we seeing. Can you tell us what we should think about that with these kids?
It is hard to know now because, a year ago, it was suggestive that maybe some kids who had that sort of multi-inflammatory system disease from COVID, that they could get retropharyngeal phlegmons, and they had other manifestation, GI symptoms, rash, and of course the mucous membranes involvement, et cetera. That was with beta variant. And we haven't seen as much with Delta or Omicron. And so I think there's a lot of unknown unknowns. It's new. It's something that didn't exist 3 years ago. And the knowledge is changing rapidly. But I think the article is very good. It's kind of like, this is the state of what we know now as of December 2022. And, we have to start thinking about long COVID and its consequences, particularly in children. We need to, they give you the signs and symptoms that suggest long COVID. I think when we see some of those patients who come in with sort of vague symptoms, fatigue, restless sleep, congestion, brain fog, mood swings, start thinking about, okay, could this be related to COVID? Of course, one of the challenges, a lot of kids haven't been tested for COVID. When they were sick, a lot of kids still aren't vaccinated. The other thing is still thinking about, we need to protect ourselves from COVID. As an otolaryngologist, pediatric otolaryngologists in particular, you're exposed to a lot of respiratory viruses in the clinic. I remember 5 years ago before COVID, I had a tracheostomy clinic. I still have a tracheostomy clinic, but I would get sick about once a month, viral infection, cold. And it was just, I was constantly around kids with tracheostomy tubes, constantly around snotty nosed kids. And we started wearing surgical masks, and then we started wearing N95 masks. And all of a sudden, I wasn't getting sick every month. And it really drove home just how easy it is for these viruses to spread in closed environments, particularly amongst being around children. And so continue to think about that. Should we be wearing N95 mask? When do we wear N95 mask? Just examining a child, and they mentioned this in the article, is potentially an aerosolized generating procedure. Just looking in their mouth, because they're going to scream at you. And so all those things are just continuing to evolve. And I think that remains the big thing, is just the unknown unknowns, and just keeping in mind to stay up to date and continue to read Otolaryngology Clinics when they come out with their COVID update in 2023.
Yes, unfortunately, I think we may have to. We did, in fact, record a special podcast just on COVID updates. But then you're right. It's the constant change in the information that we have to interpret it for ourselves and then interpret for our staff, our colleagues, and our patients. So I have left the most difficult and perhaps the most meaningful conversation for last here. And first, I want to thank you both for highlighting the importance of healthcare inequity in pediatric otolaryngologic care. So the article written by Patisapu and Rao details the difficulties that marginalized people in our society have in accessing evaluation and treatment for a variety of conditions, ranging from very common things like sleep disordered breathing and adenotonsillectomy, including post-tonsillectomy care and pain management, as we discussed earlier, including treatment of otitis media, not getting pressure equalization tubes when they need them. So, in fact, these children in difficult growth situations also now have a 25-30 dB conductive loss for longer than this. And then they go into sort of more complicated things like the lack of access to hearing health care for children who need hearing aids or cochlear implants, to tracheostomy issues that we've talked about already. So, Elton and I were just kind of talking before we started recording, and you could be the best person on earth, but if your implicit bias is to not see that other people may not have had the same kind of upbringing that you had, the same level of comfort that you had, the same access to healthy food choices that you had, the house littered with books and reading materials and maybe board games, you can't see that the home environment will impact healthcare outcomes. And I remember the very earliest papers looking at healthcare outcome disparities in head and neck cancer in poor urban communities of color, trying to open up that door. But now I think as more of us in practice come from different backgrounds and perhaps can see things differently, we're addressing this more, which I think is wonderful. So how do we fix this problem? I want to know your solution, because then I'm going to implement that SMART protocol and make it happen. So Elton, I'm going to start with you.
Just like anything else, can't fix an issue or a problem unless you recognize it to be an issue and a problem. So one of the things that I read their great article is that as you go down the list of diagnoses that we see in pediatric otolaryngology, if you actually do the work and study issues surrounding healthcare disparities in pediatric otolaryngology, the areas of pediatric otolaryngology and the areas where there's healthcare disparities in pediatric otolaryngology are one and the same. You go down the basic adenotonsillectomy, and once again, there are so many passionate people in this area. It's not just adenotonsillectomy, it's each phase, who gets, what families get offered, how are they managed, post-operative care, the list goes down. You look at the diagnosis and then you do subsets of each diagnosis and surgery, you're going to see it. Hearing aids, cochlear implants, offering up ear tubes. So I think just continued recognition is kind of the first thing. Really what the article does, and I think it's important for all of us, is health disparities to what extent and in what type. So with respect to age, gender, race, ethnicity, even things that may not be at the forefront of your mind, gender identity, zip code, geographical location. We all think about insured status, metropolitan versus non-metropolitan, number of miles traveled for care for a lot of our patients. By the time we are an academic institution, so sure, you can say if they have the need for a coronary care condition and they have to travel, that is maybe understandable. But sometimes you see the patients that you have that are traveling so many miles for care that you realize probably can be helped. In the community, it's astonishing how much, and I can't imagine when gas prices were at their highest earlier this year. And so it's that recognition of what is the problem, and what are some types of the problems and the areas within healthcare disparities that we have to tackle. Fixing the issue is such a hard problem, but the article did give a little semblance to what we can do. That the more we adhere to standardization protocols and guidelines, then a lot of the disparities can be decreased. We all know that whether it be yourself or colleagues, like nobody's trying to purposely discriminate against patients, but it is implicit bias. So it's meant not to be at the forefront of your mind. So whatever implicit biases you do having like adhering to guidelines, adhering to these protocols do seem to help. One specific example from the article was talking about rates of offering tonsillectomy. Disparities seem to close the gap between different racial and ethnic groups with adherence to the guidelines. Continuing to develop the clinical guidelines and encouraging adherence seems to be at least one of the things that we can do to continue to improve healthcare outcomes in our various groups. So continue to study, continue to develop, and continue the cycle to improve outcomes for all of our patients.
Terrific answer. And as somebody who's written a few of those clinical practice guidelines, this is a beautiful, unexpected outcome of such data. So,
Right.
Romaine, what's your dream and how do we make it real?
Elton hit most of the key points. I will say two things. One, equity is not a bad word. It's something that we need to achieve. It's one of the key domains of quality. It's one of the key domains of providing care. To be equitable, it is not a bad word. It's something we should strive towards. The same way we strive towards being efficient surgeons, same way we strive towards having low rates of complications, we should strive towards equity. Something simple that you can do is just try to create like an equity scorecard. Measure your practice outcomes with equity in mind. So, Dr. Lambert mentioned distant travel. So, okay, well, let's look at our length of stay, or let's look at for tonsillectomy. Let's look at for our tonsil patients. Are we getting more phone calls from patients who live far away? Are we getting more phone calls from patients whose preferred language is not English? Are we getting more phone calls from patients who live in more disadvantaged zip codes? If you see those patterns, then you can impact that. And that can be something very simple, like, oh, okay, my patients who have a preferred language that isn't English, they're calling a lot with questions. Let me figure out a way that I could do better education upfront for that particular group of patients. That could be something very simple to increase equity, but you wouldn't know if you don't have things built into your quality improvement analysis of your practice. So again, it goes back in my mind, you got to practice quality improvement. And then once you start practicing quality improvement, you add equity as one of the measures that you're interested in. And you just overall, equity is not a bad word. It is not something that should be discouraged or frowned upon. It is something that should be embraced and rewarded for having achievements in improving equity.
Thank you. Today, I've been speaking with the guest editors of the December 2022 issue on updates in pediatric otolaryngology, Dr. Romaine Johnson and Dr. Elton Lambert. Dr. Johnson is professor in the Department of Otolaryngology, Head and Neck Surgery at the University of Texas Southwestern Medical Center in Dallas, Texas. He holds the Beth and Marvin Cub Professorship in Pediatric Otolaryngology, and he is the editor-in-chief of Laryngoscope Investigative Otolaryngology, which is the open access journal of the Triological Society. Dr. Lambert is associate professor in the Division of Otolaryngology, Department of Surgery at Texas Children's Hospital, in the Bobby Alford Department of Otolaryngology and Communicative Sciences at Baylor College of Medicine in Houston, Texas. They both got their academic promotions this year in 2022. So congratulations, Professor Johnson and Associate Professor Lambert. That is amazing accomplishments during a difficult time. It's amazing accomplishment even during easy times. Thank you both so much for preparing this issue and for spending the time to talk to me about it today.
Thank you for joining us for this edition of the Otolaryngologic Clinics Podcast series. For an exclusive discount on the issue we discussed today, focusing on updates in pediatric otolaryngology, visit us.elsevierhealth.com/expert. Otolaryngologic Clinics is available for individual print subscription with accompanying online access or individual online-only access, and is also available on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Otolaryngologic Clinics Podcast wherever you get your podcasts.